Looks like you need a vacation. Enter the 5-Hour Energy Where Will the Tide Take You sweepstakes. You could win a $10,000 dream beach vacation. Imagine jet setting off to a tropical paradise, having fun in the sun, or diving at a gorgeous reef. It's up to you. No purchase necessary. Go to 5HETide.com for official rules and to enter. That's 5HETide.com. Enter today. Ends June 30th, 2024.
Hi everyone, I'm Deb Flashenberg. Welcome to Yoga, Birth, Babies, a podcast produced by Prenatal Yoga Center. We will be diving into everything prenatal yoga, birth, and baby related, hoping to inspire, educate, and empower you through your journey into motherhood. Thank you for listening. Hi everyone, I'm Deb Flashenberg. I'm your host for Yoga Birth Babies, and today we're going to talk all things cervixes. I have Carly Nuttall and Ali Feroah. I probably should have asked them how to pronounce their names before I recorded this. And they're the hosts of Birth Kweens podcast, a weekly show that delivers in-depth information about pregnancy, birth, postpartum, and women's health in a lighthearted and fun way. Carly is a midwife and hormone specialist, and Ali is a birth and postpartum doula and photographer. Between them, they've attended nearly 1,000 births and have over 20 years of experience in helping families navigate the journey of pregnancy, birth, and beyond. And I've been listening to Birth Kweens, and these ladies are a hoot, and I just adore listening to them. So I reached out and I said, hey, will you come on Yoga Birth Babies? And they said yes. And it was just so much fun talking to them. And we're going to talk about the cervix, mainly about the cervix before labor, during labor. Do you need to check it? What are cervical exams? What are they looking to do? It's a really fun conversation, and these wonderful people have amazing information to give. Before we jump into that, by the time you're listening to this, we would have moved into our new yoga space in the Upper West Side. Woohoo! Yay for us! It's been a couple months in the works of planning, and we're finally doing it. So we're opening on the 16th of September. I'm so excited. And I want to say a very deep-hearted thank you. The community has really stepped up. I started an I Fund Women crowdfunding campaign, and I am blown away by the generosity of our PYC community. Thank you. Thank you. Thank you. I truly could not have done this without your generous contributions. And the I Fund Women crowdfunding campaign is still on for 2 more weeks. You can find it on our website, prenatalyogacenter.com, or go to I Fund Women and look for Prenatal Yoga Center. So thank you. Truly, this could not have happened without you. Also, what could not happen without you is this podcast. So please take a moment, if you're enjoying what you're listening to, leave a rating or review wherever you're listening to it. And then last little blurb of information I want to share is we're starting the New York teacher training very soon. I'm incredibly excited. We have a wonderful group of people. It was a packed group. We had a wait list. So I'm excited to meet with those that we're going to work with. And then pretty soon we're starting Charlotte, North Carolina, and then Washington, D.C. is getting very limited with space on how much we can fit into our teacher training. It's really starting to fill. And then we'll be back in New York in the spring, and then back to Richmond, Virginia in the late spring. So a lot of opportunities to work with myself and Caprice, but they are filling. So if you want to deepen your practice as a yoga teacher and start studying prenatal yoga, please check it out. If you're a yoga teacher that your passion is not prenatal yoga, but you just want to have the skills to work with the pregnant student that shows up in your class, check out Who's Afraid of the Pregnant Yogi. It's an online course specifically for the yoga teacher that might freak out when a pregnant student comes in, and ignoring that student is not the answer. So I give you some help with that, some guidance. Okay, that was enough of me talking. We'll take a super quick break, and when we come back, we're going to hear from Carly and Ali. It's a great conversation. Enjoy.
You know how to book flights and hotels. All you're missing is a tool to plan the travel experiences you'll have once you arrive. That's why you need Viator. Book guided tours, excursions, and more in one place. There are over 300,000 travel experiences to choose from, so you can find something for everyone. And Viator offers free cancellation and 24/7 customer support for worry-free travel. Download the Viator app now and use code Viator10 for 10% off your first booking in the app. Find travel experiences for you. Do more with Viator.
Hi, Carly and Allie. How are you today?
Hi.
We're doing so great.
We're great. We're so happy to be here with you.
Yay, thank you. As I was telling you before we started recording, I love listening to Birth Queens. You guys are a hoot, and I can tell you are probably super good friends, and it just feels like I'm just checking in a conversation with two good pals talking, which is exactly what I think podcasts should be. So thank you for putting that out in the birthing world.
Thank you. It's such a nice compliment.
That's totally our goal with it, is like, because we are pretty much how we are on the show.
Yeah.
Just how we are with each other. And
probably a little less censored even.
Yeah, on the show?
Yeah, a little.
Yeah,
maybe,
no,
less censored in person.
Sure. Well, yeah, I mean,
we keep it together a little bit more on the show. Which would come as a surprise to many people.
That's how my co-teacher trainee and I are. We're very kind of like boppity bop right back and forth. And people are like, you guys like a two-woman show. I'm like, we are.
Yeah. That's the goal here.
It turns out.
This should be entertaining.
I am beyond excited to talk about cervixes or cervixi. I don't know what the plural is, but
cervices? I don't know even how you say it. I should. I'm a midwife.
Right?
I should know. But yeah, I'm usually only talking about a cervix in the singular.
Right.
And so
But now we're talking about many cervixes.
Yeah. But there are a lot of things like uteruses. We just call them uteruses instead of
uteri.
Cervixes. Yeah. It's just, there's like the official way, and then there's
the regular way.
Yeah,
how we're all
in
going to say it.
how we all talk about it.
So I listened to the podcast you did about this, and I was walking down Broadway at like a 30-block walk, and I'm listening. I'm like, yes. And people were, I was like saying this out loud, and people were looking at me like, who's the crazy person? So immediately I'm like, okay, we have to dive into this. So this is so exciting. So I guess before we get into the whole world of cervixes, plural, if you wouldn't mind just telling me a little bit about yourselves and how you both got started in this work.
Yeah, sure. Okay, this is Allie, and I am the doula half of this pair. And I'm a birth doula and a postpartum doula, and I also do photography, newborn birth, family photos. And I got started, I've been attending births for like 6.5, little over 6 years. And I always joke that it was like an accident that I got into birth work. I was the kid who like would pass out and throw up when I got my blood drawn. Like I did not want to talk about bodies or know about bodies. Like didn't
even want to exist in your body.
Nope. Was a not weird, but just an anxious child who like wasn't interested in that. And, I even to the point where I saw my mom have a baby when I was 14, my youngest sister. And I was like, I mean, I'm obsessed with her, but that was horrible. Like, I can't believe you guys let me be here. I just wasn't prepared is what it was. But fast forward to, I'd graduated college. I had moved to San Diego, went to school, graduated, and was like sitting on my couch looking for a job. And I was also, while I was looking for a job, just like eating and watching Netflix like you do. And I watched the documentary, The Business of Being Born, which really opened my eyes to the state of maternity care in America. And it was kind of the thing that lit a fire in me. I was just fascinated. And I picked up a book by Ina May Gaskin, who's interviewed in that film. And for the next year, I like couldn't get enough information. And luckily I did find another job shortly thereafter, but I spent the next year and a half, like reading and learning everything I could. And met somebody who was a doula who knew of a volunteer program, and it all just kind of fell into place. And so I became a volunteer doula at first, and then eventually quit that other job and did this full time. And here we are. So it's been really amazing.
And Carly, and then also how you guys ended up working together. So
yeah. Carly, tell us about yourself.
My name's Carly. I am the midwife side of the duo. And I went to my first birth 20 years ago when I started midwifery school. It was almost a year after I'd started midwifery school. But I got interested in it because my mom had a couple of home births. There are 8 kids in my family, and the first 6 of us were born in the hospital, and the last 2 were born at home. And my mom was always like, oh, I wish I'd had everyone at home. It was so great. Midwives are so awesome. And so I was just raised thinking this is what everybody wants, is to have a baby at home. I mean, I was also raised thinking everyone wanted to have 8 kids or maybe like 12 and they fell short by the goal, like, by 4 kids. But that was just how I got into it. It was just kind of blindly. Like when I was 17, my mom was like, why don't you be a midwife? And I was like, that's a great idea. Yeah, I'm going to be a midwife. And so I just walked into it like that. So I started midwifery school when I was 19 and, started going to birth, started studying and started my own practice eventually. I did a lot of internships. I did a lot of apprenticeships. I mean, it wasn't as inspiring as Allie's story. I just dumbly walked into it.
That's not true.
Hello, midwifery.
Yeah.
Here I am.
I love your story because it's like not everybody is for a lot of people, it's a calling, but it isn't always. And you don't have to be like, oh, I was struck by lightning with this like calling toward birth work. Like, I don't know. I think that's an important message for what it's worth.
I agree.
Because a lot of people want it to become more normal, more mainstream, not like a calling to be a midwife, but
I think I was between the two of you. I was teaching prenatal because honestly, it comes back to my mother again. Kind of like you just said, your mom. My mom's like, totally. Why don't you teach the prenatal population? Someone's always gonna be pregnant. I'm like, oh, okay. Like it just, And then I fell in love with the birth advocacy of it after seeing hospital births. But yeah, sometimes it's a calling, sometimes it's a mere suggestion, and I like that for Carly and I. It's by our mothers. Why did you look into that?
So my mom, meanwhile, was a labor and delivery nurse and lactation consultant for years, and she was like, "You want to do what? Like, you are not gonna." I don't know about that. So,
well, they're long hours. Doula work and midwifery work, they're very long hours. It's very physical. I don't think people always realize that. So, what brought the two of you together?
A fateful car ride to one of our mutual clients' homes.
Was that okay? Well, we first met in passing at a birth center in town where she worked, and I was a volunteer doula. And then
it was so brief. It was literally
so brief,
I got there as the couple was transferring. Hi, Allie. Bye, Allie. Like they were just walking out the door. And
then we, met a mutual client. It was that car ride, huh?
Yeah. Yeah. And it was a long car ride. It was about 45 minutes and we laughed the whole way there and the whole way back. And then we were like, oh my gosh, let's be friends. And then I think later that year I had taken some classes and I came to Allie and was like, what if we started a podcast? And foolishly she said yes. She regrets it every day.
No. But this our whole thing was definitely Carly's brainchild. But it did just start off we had a couple births together that summer and we I don't know if we can speak for the people giving birth, but we had a great time.
We had a great time.
Yeah, it was amazing. So here we are a couple years later.
How can we work together all the time? We can't go to births all the time together because people don't always hire us, but we could do this together. So here we are.
Oh, it's great. And I appreciate the work that you guys do. So, all right, let's jump in the talk of cervix. So let's go super, super basic because I don't always know who the audience is. Let's talk about where and what the cervix is and why is it something a care provider puts focus on?
Well, I love this question because so many people are unaware of their own physical anatomy, especially when it comes to the cervix and the female reproductive system, because it's so hidden and internal, and people that have a vagina are usually only familiar with their vagina and the labia. But the cervix is at the end of the vagina, and it is the lower segment of the uterus. So the uterus is a little pear-shaped organ with the cervix at the bottom, and it has a hole in it. And so that's what opens when you have your period, when your blood comes out. And the reason that it matters in labor is because a baby can't come out of a closed cervix. It has to open in order for the baby to be able to come out through the vagina. So that's why it matters.
Mm-hmm. Okay. So let's start talking about dilation. So I feel like that kind of gets the main shining focus. Can you talk about other parts of labor one would want to consider and other factors besides just dilation?
Yeah, that's a really good question. You're so right. I feel like whenever we're talking about the cervix, especially in labor or even at the end of pregnancy before labor, the only thing you're really ever hearing about is, well, how far dilated are you? And that's measured in centimeters. you're, closed is 0 centimeters dilated all the way up to 10 centimeters dilated, which is considered completely dilated or completely open. But there's actually 5 different things that when a provider does an internal cervical exam or pelvic, vaginal exam, what they're assessing, and they're all an important part of the picture. So in addition to just dilation, which is how small or, wide or open that opening is, they're also feeling for the ripeness of the cervix, so how soft or firm it is. And an unripe cervix, or like our cervixes sitting here right now, are nice and hard and firm, like the tip of your nose. Whereas a ripe cervix, or one that is ready for labor or in labor, is really soft and squishy, like your cheek, which I'm like doing the thing where I touch my nose and my cheek right now. You guys can't see me.
It's like you're testing for how done is my hamburger.
Exactly right. So there's the ripeness. There's the position of the cervix. So pre-labor, and sometimes even into early labor, but especially pre-labor, the direction that the cervical opening is pointed that changes throughout the labor process. So it starts off pointing in the posterior direction, or pointed a little bit toward your back or your butt. And as labor progresses, I should say sometimes in labor, sometimes before labor, your cervix will shift to be more like midline, and then eventually an anterior cervix. So it's more in line with the vaginal canal, the vaginal opening.
Making a straight shoot for the baby to travel down.
Totally. And that is an important note. People, I'm sure we'll get into like cervical exams before labor starts a little bit later, but the position of the cervix makes a big difference for how comfortable or intense a cervical exam can be. And usually before labor, that opening is really pointed back, which means it's often hard to reach or hard to feel. So something to keep in mind.
With the Lucky Land Slots, you can get lucky just about anywhere.
This is your captain speaking. We've got clear runway and the weather's fine, but we're just going to circle up here a while and get lucky. No, nothing like that. It's just these cash prizes add up quick. So I suggest you sit back, keep your tray table upright, and start getting lucky.
Play for free at LuckyLandSlots.com. Are you feeling lucky? No purchase necessary. Void where prohibited by law. 18+ terms and conditions apply. See website for details.
Lucky Land Casino, asking people, what's the weirdest place you've gotten lucky?
Lucky? In line at the deli, I guess?
Aha, in my dentist's office. More than once, actually.
Do I have to say?
Yes, you do.
In the car before my kids' PTA meeting.
Really?
Yes.
Excuse me, what's the weirdest place you've gotten lucky?
I never win and tell.
Well, there you have it. You can get lucky anywhere, playing at LuckyLandSlots.com. Play for free right now. Are you feeling lucky? No purchase necessary. Void where prohibited by law. 18+. Terms and conditions apply. See website for details.
But the other 2 things are effacement, so how thick or thin a cervix is. If it's 0% effaced, that means it's nice and thick. So is it usually
about 4 centimeters long?
Okay, yeah. And then as you progress in effacement, it gets thinner and thinner up into the point of 100% effaced, when they say it's
basically like paper thin.
Yeah, teeny tiny.
Yeah.
And then the last thing is the station of the baby. So that's less cervix centric, but it's still a really important part of like how high or low they are in your pelvis. So that's like the full picture, and that's way more than just how open your cervix is.
Yeah. Well, you can glean even a little more information from doing a pelvic exam like that when someone is in labor, because once the cervix is open enough, you can also determine is the bag in front, is the
bag
bulge,
of waters.
Yeah, the bag of waters, is it intact? Is it in front? Because some people are going to want to rupture that to get labor to move along, so that's going to be another important piece of information you can get from it. And when the cervix is open far enough, you can also sometimes feel the baby's suture lines. So the suture lines, it's the space in between the bones of the baby's skull, and being able to feel those sutures can tell you where in the pelvis the baby's head is positioned, which is really important. So if the baby's head is posterior, so it's the back of the baby's head is facing the tailbone, that's a bad position for the baby. And if you can determine,
can make it more difficult for labor to progress.
Usually every once in a while, someone has a great pelvis to accommodate a baby who's in a posterior position. 99.9% of the time, that is not the case. And it causes a lot of back labor, which is more painful than having just regular old contractions. And it can make it really hard to push. It can make it hard to push the baby out effectively because it's not, the pelvis is not generally meant for a baby to come through it in a posterior position. Like if we were doing video right now and I had my little, like my little demo doll and my little demo pelvis, I could show you how much easier it is for a baby to fit through the pelvis if it's going through with the head facing the anterior. So that's another thing that we look at too, because if we can confirm that the baby's head is asynclitic, so cocked off to the side, or if it's posterior, or if it's in a good position, then that helps us determine what positions we'd like the birthing parent to get into so that we can work with that position and change it to get a more efficient labor.
Absolutely. I love everything you said, and I totally agree with it. And I think we want to encourage our pregnant students to know that there's more than just dilation. Especially, I love that you check out the suture lines, because I've been to many a birth where I ask baby position. I've actually been told by a couple of doctors, like, oh, it doesn't matter. And then I feel like a big fool because I'm like, we got to talk about baby position. You're like, where's the spine? So the fact that you're looking for that as a midwife, because we know if the baby's better positioned, it's going to be a more functional birth. So
absolutely.
Yeah.
And there are things you can do to encourage like different positions for the birthing person to take
absolutely.
that can adjust or change or impact how a baby navigates the pelvis. So that's part of our job as people, I think it is, people who are attending births and supporting births, despite what some doctors or care providers might think.
Well, I think bringing that up is smart because it's important to note that not all care providers are the same. Yeah. And to some doctors, it really doesn't matter because they are not attached to you having a vaginal birth or a cesarean birth, and they can do a cesarean. So to them, it's like, well, if this baby's not going to come out of your vagina, I am happy to cut it out for you. And they don't have any kind of emotional attachment to that. And so, not every care provider is going to look for that, but absolutely it impacts the ability of the baby to get through your pelvis.
And then for the birthing person to ask more than just, okay, what's my dilation, but even say like, what's the station, how high low that baby is. And then again, where is the baby? Because then if the care provider may not offer, all right, baby's asynclitic, let's try A, B, and C, which they likely aren't unless it's a midwife that I've seen. At least maybe the person that's birthing could come prepared knowing, okay, if I find out the baby's, posterior asynclitic, I can do, all these options. So if they come prepared, that information from the cervical exam could help them instead of just leaving them like, all right, now what do I do? So I'm so glad you touched upon that. So I guess
it's useful information for a doula as well. Because, someone who's in labor is generally not in the mindset of, I'm going to manage my own labor. If it's really intense,
they shouldn't be, but they
shouldn't. They really shouldn't be. And at a certain point, they really are not able to. If you're maybe with an epidural, but if you are, drug free and you're doing this and you're in transition,
your birthing mind.
It's so overwhelming, and you cannot even think about anything except for how am I going to get through this contraction? Like breathe. And so, ideally everyone would have someone with them who could advocate and who could help them into positions. And there are getting to be more and more delivery nurses who are taking spinning babies and are aware of what different positions and stretches you can do to help the baby into a better position. But it's not something to count on from a labor and delivery nurse because they change every 12 hours too.
Yeah.
Well, the ones here in this city, in New York City, they're covering 2 or 3 rooms at a time. So they're certainly not giving one-on-one attention. And I guess I was thinking like the majority of, I'd say a good, maybe half of my students have a doula and the other half rely on their partner and themselves to get through this. So hopefully they can then share this information with their partner and maybe have taken some sort of support course ahead of time about what this information can mean and how that could then help them in their birth. But I guess also we need to talk about what is a cervical exam. We've talked about what they want to find out, but can one of you talk about what is a cervical exam and how is it given?
So cervical exam is when your care provider puts a couple of fingers into the vagina to the cervix, and then using our middle and pointer finger, we measure how open the cervix is, kind of feel around. It can take a few minutes. It's not just a quick like zoop in, zoop out. Like you have to feel around because sometimes the cervix is very confusing. Sometimes it dilates unevenly. Sometimes it's extremely posterior and the front part of it is so thin that you can't really feel like, is this person fully dilated? Where's the cervix? Do they even have a cervix? What's going on? So it can take a couple of minutes just to fully assess, especially if you're trying to feel the suture lines on the baby's head. That can take a little bit longer. So it can take up to a few minutes to do it. It depends. The comfort level of your exam depends on a few things, like how gentle your care provider is, how big their hands are. I have teeny tiny elephant hands, and usually it's no big deal for me to do a cervical exam, but that's how it's done.
Okay. And I would like to add into that so how these things are measured is certainly taught in a somewhat standard way, but it's a bit subjective. So if you get, as much as possible, I think that there's a huge benefit to having the same person perform your cervical, if you're getting more than one cervical exam, especially in labor. And, we don't always have control over that because of shift change or whatever. But if possible, to have the same person do the exam, there's benefit in that because everybody's what am I trying to say?
They don't go up there with a protractor.
Exactly. Yeah, it's very subjective. So if the same person does it, they can just say this feels different than the last time I felt this person's cervix. So
because the differences could be subtle.
Totally.
Which is great. Yeah. In labor, usually they like to do a cervical exam at the hospital every 4 hours. Some hospitals, it's every 2. I mean, there's a really wide range of what's normal based on the hospital and the provider. It used to be that it was every 2 hours that they like to give a cervical exam just to see what the progress is like. And now there are quite a few hospitals here, at least, where, especially if your water is broken before you get to the hospital, or if your water is broken at all, period, they only want to do it every 4 hours unless it seems like, okay, well, the baby's coming out now, so maybe we should
drastic
maybe we should check and see if you're fully dilated.
What about the idea, and I'm kind of jumping around in some of these questions I prepped, but what about the idea of declining a cervical exam and also just even when making sure someone gives consent to having a cervical exam?
That's a huge thing.
No, it can be a real issue. One of my clients told me that with her first birth, she was getting induced at the hospital, and she was in the middle of the induction. She wasn't having contractions yet, and she was asleep, and her care provider came in while she was asleep, and actually she was asleep, and her care provider put her hand into her vagina while she was asleep. She woke up to somebody, which is it's sexual assault. I mean, it's so there's some really shady things that happen there, and I mean, she didn't have time to consent or not. That was. It's something that happens in the hospital more frequently than it should. But yeah, I mean, you absolutely can decline. For me personally, it would depend, as a care provider, understanding the value of an exam. Some people just want an exam because they want to know what's happening. They want to know, I've been having all these really strong contractions. I've been doing all this work on the baby's position. Yeah, I want to see, did all of this effort result in some kind of change? Did the baby come down a little bit? Is the baby's position different? What's going on? And so, by all means, people can decline, or they can just decline to know what their cervical exam resulted in. That's helpful for some people. And so, yeah, it's something to talk to your care provider about. Some care providers are kind of bully-ish about it.
Yeah.
I've had some clients that I've had to transfer to the hospital where they've declined verbally, and the doctor's like, we have to, sorry. And they just do it anyway. So
yeah, there's in my experience from seeing lots of home births and hospital births is that typically, unless, and this is just for our little bubble here in San Diego, my experience at all the hospitals I've been to around town is that unless you can always decline anything, certainly, but unless you are walking into the hospital in labor with a baby coming out of you, they're usually not going to want to admit you or do anything else procedure-wise until they've done that baseline exam to see where you're at in labor. So it's I've had some moms in the past who were really nervous or had a history of abuse, and the cervical exam thing was really scary for them. And the, possibility was upsetting, and their hope was to get an epidural before they had an exam. And that hasn't been successful in my experience. Like most providers,
I've had the same thing in New York, that people want to know, the hospital wants to know what the baseline is. They don't want to admit someone at 1 centimeter, even though they might be presenting like it's more intense. Yeah. They'll tell you to, lovingly, maybe not lovingly, but they'll tell you to go walk around.
And I think that's important. I know it can be so hard to hear when you're like working hard in labor and things are intense, but it's your first baby and you get to the hospital and maybe you're 3 centimeters. If the goal is a low intervention birth, baby and birthing person are both healthy and low risk, the best thing is to go back home or keep laboring before being admitted. Like if you can get to active labor, which is considered 6 centimeters, before you check in at the hospital, that's amazing, because your chances of intervention, of labor slowing down, of you being kind of forced into a timeline that doesn't fit your body and your baby are so much lower if you can do that. So I think cervical exams can get a bad rap, but you can get some really valuable and arguably essential information, at least from my perspective. And I know Carly feels the same way. Like, they shouldn't be done constantly, but there is good, helpful information to be gleaned from those.
Great. Let's jump into that, because I feel like sometimes I hear everyone's like, no vaginal exams or cervical exams. And I feel like, yeah, I agree. There definitely could be information. So let's talk about some justifiably great reasons one may want to have a cervical exam.
Yes.
Good question. We're big fans of this because we've both read articles of like, you don't need a cervical exam to have a baby. And certainly we've been to births where you didn't, like one wasn't required, but
yeah, I've done plenty of births where I walk in, it's someone who's had a kid before. Obviously labor is progressing. They get to a point where they sound like they're pushing. They start pushing. I'm seeing a baby's head within 20 minutes. Everything's fine. There are a lot of circumstances under which it is beneficial to get a cervical exam. I would like to address first that a lot of people think that a cervical exam is just to see when the baby's coming. Yeah. A lot of people, like, the only reason people do cervical exams is because they're impatient and they want to know when the baby's coming out. And that's not going to tell you when the baby's coming out. And it's not. The reason that I do cervical exams is, am I going to change something about the care that I'm providing and the support? And that's not the case for every provider. Every provider is different. And some people are just going to check out of curiosity. I'm not speaking for everyone, but that doesn't change the fact that these are very useful for a lot of people. So one of the times that I think it's really important is, I don't know, sometimes it actually just changes people's ability to cope with their labor. So I've gotten calls from people where it was like a 3rd-time mom. She called me, I'm pushing, you got to come quick. I got up there and she wanted me to do a cervical check, and I did. And she wasn't even in labor. I could tell just from her cervix. It was long, it was closed, it was firm. And she didn't have the baby until a week later. So I was like, well, the good news is that you're, not having a baby today.
Good news or bad
news is also that you're not having a baby today.
Yeah.
And so her contractions actually stopped after that.
She was having contractions.
She was having contractions, and she's just somebody who has a lot of prodromal labor. So she was having contractions, and then they stopped. And so at least she wasn't like uncomfortable, and she could go throughout the rest of her day because she wasn't in labor. She's just having prodromal labor. Another time is, when we're trying to decide, like, should we transfer to the hospital?
This is like specifically from the perspective of a home birth care provider.
Yes. Thank you for clarifying that. Yeah. Allie's always really good to clarify, because she goes to both home births and hospital births a lot. And for me, I'm just like home birth centric.
Yeah,
all I think about, except that we do have to go to the hospital sometimes. But anytime you're going to make a big change, like if you're going to get an epidural, some people will be having this labor where it's like, oh gosh, I've been 3 centimeters for like 15 hours. I want the epidural. And then maybe things have gotten a little more intense and they just assume I'm probably still 3 centimeters, but then they get a cervical check before they get the epidural and they're actually 10 centimeters. So, labor is not like the dilation of the cervix isn't always linear. Sometimes it is, sometimes it's not. But if I were going to be in the hospital and I was thinking about getting an epidural, I would want to know if I, had suddenly made a leap in progress,
totally.
Sometimes that happens. Or, if we were going to get wheeled back for a cesarean, I would want to know for sure, like one last time, if the reason that we were going was lack of progress, has there been any cervical change, and sometimes that's going to make a difference in what you do. Like one of my clients was planning to have a hospital birth a couple weeks ago, and she had been 3 centimeters at her previous exam. And when I got there,
during labor.
It was during labor. Yeah. So it was like 4 hours prior. And I got there and she was like, I need an epidural. I need to get this epidural. And, we kept asking her, like, do you want to get a cervical exam first?
Yeah.
I mean, your dilation may have changed drastically. She's like, no, I just want the epidural. As soon as they got the epidural in, she was fully dilated.
Yeah.
Fully dilated. And so, she may have wanted to complete that without the epidural. I think she was fine with the epidural, but that's a reason why. Another big one for me is if people have any scar tissue on their cervix. So if you've had something like a LEEP procedure from cervical dysplasia, or if you've had, any kind of
cryotherapy,
yeah,
is that what it's called, right? Where they like freeze off.
That is a cryotherapy. Yeah. So if there's any kind of scar tissue on your cervix, it can prevent the cervix from opening in labor unless you massage it. So I've had a few clients where they've had either, like a late term, like they lost their baby and they had to have their cervix opened to like deliver the baby, something like that. They've had scar tissue where, they're in intense labor, but their cervix isn't dilated at all. And then you just get in there and you massage the scar tissue a bit, sometimes it's like 5 minutes, sometimes it's a little bit longer. And then it just suddenly opens up. And most of those clients that I've had, they'll go from like 1 centimeter or no dilation at all to a baby in, 2 to 4 hours because it's, suddenly released it and the cervix can actually do its work. So that definitely if people are having signs of malposition, like if the baby's, if they're experiencing back pain during their labor, that's their greatest pain. I definitely want to see what's going on then, because if we can tell that the baby's malpositioned, there's a lot of stuff that we can do specifically for the position the baby's in. Another one would be, I just remembered it. And then I just lost it.
You lost it?
Yeah. Where did it go? Oh, cervical lips. So,
yeah.
I
talked about like the urge to push.
Yeah. So let's say, some people have an early urge to push. Like if people have an urge to push, sometimes an early urge to push comes from a malposition, like the baby is in a posterior position. So the biggest part of the head is on the back of the vaginal muscles, and that can stimulate this ejection reflex where you want to push and you can't help it. It's like throwing up, but out your vagina.
Mm-hmm.
And
that's
so
exactly
when that
what
happens,
I always call it. I literally say it's like throwing up out of your vagina.
It is.
I've never heard anyone else say that.
Your vagina. Yes, I'm glad that we can agree on that. I think that I don't think we're the only ones, Deb. But when that happens, people are having an urge to push, especially if it's a first-time parent, especially if they've had back labor. I really want to check because it is so, I cannot describe the devastation to you of someone who's been told, follow your body, just push if you feel like pushing, and having them push for a couple of hours with no progress, and then finally checking to see that they're only 6 centimeters and that they've been putting all of this effort into pushing on a closed cervix. That is not helpful for anyone. It is so demoralizing for the person who's in labor, and it can swell the cervix, and it can make it even more difficult to have a vaginal delivery. And so that's one of the reasons that I really like to check when people feel the urge to push. Another is that the cervix can be mostly dilated, so it's, I can't think of an analogy. I guess if you get like a wonky shaped donut that's like thinner on one side and really fat on the other, it's kind of like that.
It's like a cervix. It's like a lifesaver that you're sucking more on one side than the other.
Yes.
Yeah.
That's it.
Yeah. So it can be like totally thinned out in the back, and usually when there's a lip left from the cervix, it's in the front. So if that's the case, that can completely prevent the baby from making any descent. So you're putting all of this hard work and effort into pushing, and nothing is happening. Like the baby's not coming down at all. And I see that happen, whether you're a 4th-time parent, a 3rd-time mom, a 1st-time mom.
It can happen.
It can happen. Yeah. And so for me personally, if someone's already had a baby vaginally before, if they haven't delivered the baby in 30 minutes from the start of pushing, then I start to get suspicious, because you're not going to ruin your cervix by pushing on it for 30 minutes if you're not completely dilated. So, to avoid doing a cervical exam, then a lot of times I'm just like, oh yeah, you're ready to push. You, mother of 3, great, let's do this. And then if I don't see the baby in like 20, 30 minutes, then I start to wonder what's going on. But yeah, a lot of times you can just hold the cervix out of the way. Sometimes you can't. And if you can't, you just need to have the parent labor on like alternating sides, 3 contractions on your left side, 3 contractions on your right side, or do some stuff to try to reduce the swelling, like homeopathics or whatever. But having a cervical exam really, really affects care a lot.
I 100% agree. What about those that and what are reasons someone may want to opt out of an exam?
Yes, good question. I think that anytime you have a provider who just wants to do an exam because it's been 2 hours and we do them every 2 hours or 1 hour or 3 hours, like just because solely based on time and not necessarily any change in a labor pattern, that's a time to ask more questions and ask, hey, what information will I glean from this? Has my body had enough time to make any measurable change that this exam is warranted? If your water bag has released, there is an increased risk of infection especially with every vaginal exam you do. And yes, providers use sterile gloves, but it is still something going into your vagina and introducing bacteria. So I like to be very cautious and conservative, or, talk to people about being conservative about accepting exams in those cases. I've had some situations at like teaching hospitals or where there's somebody learning who the nurse, doctor, whoever does the exam, and then they want their student to be able to do an exam right after so then they can compare notes. And I get that that's for learning, and it's super important for getting new providers kind of trained. But I always tell my people that you don't have to be the one that anyone learns on, especially if your water bag is broken, especially if you are unmedicated. And because usually cervical exams are not comfortable. Some people don't mind them, but typically they're like, you have to almost always lay back, reclined on your back, butterfly your knees open. The more you can like relax and soften those muscles, usually the easier the provider is able to adequately assess everything. So doing that in labor can be really hard.
Being on your back in labor can be so painful.
Mm-hmm. Yeah. It's very worth mentioning for people who don't have wonderful providers who are patient like Carly here, that you can ask that somebody wait until you're done having the contraction and make sure to check in between. I know that especially in busy hospitals or birthplaces, there's providers who are like, nope, we're doing this on my time right now. Like, your magic words are, no, I do not consent to this, or I do not consent right now. I need a minute. So don't be afraid to use those and have them start when you are good and ready. And then another time, I don't know if you were going to ask this separately, but I think a really great time to decline a cervical exam is before you are in labor.
Oh my God, that is my biggest pet peeve. I can't tell you how many times my students will come in. I've had some so I get it if they're coming in before 37 weeks, maybe they're having contractions, they need to know what's going on. But I've had some at 37 weeks, it's just what their practice does.
It's standard. Mm-hmm.
And I'm like, well, how is this going to change how they manage the care? If it's just standard, like, you're fine to be at 37 weeks with some progression. And gosh, so many of my students either come in overly excited, which makes them anxious. I'm 1 centimeter, or kind of deflated. I'm nothing. I'm closed. Totally. I'm like, that could change within hours. So yes, I've seen it. I remember having a doula client. I saw her for prenatal, and that was at 10 o'clock. And then by the end of my postnatal, which ended at 1:30, she called me. She's like, you better get over here. Like a couple hours later, and she walked into the hospital, threw up on the floor, and birthed her baby not even an hour later.
Yes. It isn't. Yeah. And I talk through this a lot with my doula clients, and I never tell people like, don't get cervix. You know, I'm just not one to tell people there's no hard and fast, like always do this or never do this. Like if you are high risk or you're having lots of early labor, or they're worried about, is your cervix staying closed early on in pregnancy, then yes, that is a valid time to check and measure and see how your baby and your body are doing. But if you are healthy and low risk, your cervix is not a crystal ball. It absolutely does not matter where your cervix is at 37, 38, 39, 40 weeks until you are in labor.
Mm-hmm. And your dilation pre-labor doesn't have any implications on your labor. Like you can be dilated to 3 for 4 weeks before you go into labor and still have a 3-day labor.
Yeah.
It doesn't matter.
Which is like, I don't know if we're allowed to swear on this podcast.
Go for
it. Yeah, it's bullshit, right? We get it. That's frustrating. Or you can go from 0 to baby in a couple of hours. And this is something that Carly mentioned earlier about cervical exams in labor and how some people opt to not know, like the person giving birth will request to not know the results or the numbers associated with the labor exam. And I have a lot of families who have really good luck with that if they're birthing at a hospital and their goal is a low intervention unmedicated birth, because it helps them. What my clients often say is, I just want to know, am I far enough along to be admitted? And am I making progress if there are subsequent exams? And sometimes there's an adjustment to that approach, or something happens where, it's helpful for them to know dilation effacement station so that they can make their next best decision. Mm-hmm. But a lot of times it can get in your head. And even though you might know ahead of time logically that labor isn't linear and progress can change in kind of fits and spurts, and it can still be really hard to not do labor math.
Oh, I totally did that. And I was a doula for 8 years before having my first.
Yes.
And I had been teaching
you even
this.
know.
I did. And I knew better. And I was still like, okay, it took me this long to get to 5. And as I was saying it, I guess I was moving my lips a little. My doula's like, what are you doing?
Yeah.
Are labor math?
I totally was. And I knew better.
Totally. Right. And it's okay. Sometimes it's a crapshoot, honestly. Like some people find it very encouraging or really like knowing that information. And other people find it really demoralizing. Mm-hmm. I had a couple births this last week where it was, the birth defied expectations in a lot of different ways. It was these two I'm thinking of where it was their second baby both times. And it was just very different than the first, and very different than they knew it would be different, but it was different even than how they thought it would be different, if that makes sense. And knowing the numbers, even though we had talked about this can change so fast, especially with your second baby. I feel like I see my second timers or people after your first baby go from like 3, 4, 5 centimeters to baby in an hour or a couple hours all the time. But there was this, it felt very heavy to them to know that they were in hard active labor, walked in, or what felt like hard active labor, were like 3, 4 centimeters, and they still both had their babies a couple hours later, but the mental load of that felt like a lot.
I completely hear you. So I also had a student, when I announced I was doing this podcast, I asked him, like, what are your questions? And I had one student ask me about, she's not comfortable with a lot of hands in her vagina, and she wanted to know about checking her own cervix. And I mean, not many people are like, here, I'm going to open my legs, go for it. So she wanted to know about checking her own cervix. And I gave her a little bit of the info I had. When I went down to the farm, they taught us how to check cervixes. And I'm like, and that was, not being in labor and not trying to get around my belly. So what are your thoughts on self-examination? I was all for her getting to know her body, but if she doesn't really have any background, is she going to be able to, and she's in labor, is she going to be able to figure out the information needed?
I think it's really hit and miss. The cervix can change in really confusing ways when you're in labor. So even if you're familiar with your body when you're not in labor, it changes completely when you are. And even for someone who is checking, like not going around your belly, checking, while you're in the best position for it, it can still be really confusing. I mean, there have been times where like me and another experienced midwife actually got out a speculum because we're like, we cannot tell what the hell is going on in here. Yeah. And so it's going to work for some people. Some people will be able to check and be like, oh yeah, I can feel that it's open, but you can't always. Like the bag of waters can be really confusing. If your cervix is posterior, it's extremely confusing. And if you're squatting and you're trying to get around your big belly, you're not even going to be able to feel it.
And I was like, how is she getting in there?
Yeah. Because I mean, there are times that when so if you change your position, like you as the pregnant person change your position, say you're squatting instead of lying flat on your back, it changes how far down the baby's head feels, and it changes the position of the cervix. And so if that's, how you're trying to feel, it's going to feel different than, to someone who is checking you while you're lying on your back. Like if I know that someone, or if I assume that someone is not at least 7 centimeters, I won't check them in the tub. I will definitely not check them while they're squatting or sitting on a birth stool. I will only check them while they're lying on their back, because it's the most accurate way to get the feel for what's going on. So I think it's a really tricky one. I mean, I don't discourage anyone from like checking themselves if they want to, as long as their water's not broken. But I don't think it's not reliable across the board. And something else people ask about a lot too is this purple stripe. The purple line that's supposed to like creep up your butt crack as you're
I've
dilating.
heard about that. I've never tried to look at it or examine that, but yeah, I've heard about that. Is it real? Is this a real thing?
Well, you can see a purple line sometimes, but that's not consistent either. And I've been laboring with people where I could see the line creeping up and it got to the top and she was still at 4 centimeters. And so when people say, that there's any kind of a replacement for a cervical exam, I totally disagree with that, because I've, in practice, I've tried all the other ways that people are like, no, you don't need to do a cervical exam. And it's like, man, you can't really get around it. And again, it does matter because you can't birth a baby through a closed cervix. And so, I mean, at some point, somebody, if things are not going smoothly and a baby's not just flying out of your body, at some point, someone might need to figure out exactly what's going on with the cervix.
Yeah, because it's important. We really talked about we can really gather great information that can help, that can kind of be like, oh, this is why things aren't progressing. Like I remember with my son, his head was slightly asynclitic. So we can kind of tell because things were not progressing, besides me being a doula, and I had a doula and a midwife, like we figured something was up, but it gave the information that, okay, there's a lip. So we could figure out with this information, we can take these steps. So I like that we're highlighting it's, it doesn't have to be a negative thing, but let's talk a little bit something you mentioned, the linear or non-linearness of what happens. And let's throw in what we talked about, Friedman's curve. Oh, Friedman's curve.
Yes. We're excited. I can only speak for myself. I am excited.
All right, Allie, go. It's your turn.
Okay. So for a long time, birthing people, especially in America, I don't know if it went beyond America, but in the US, birthing people have been held to this standard of labor progress of what's quote unquote normal for how quickly a cervix should dilate and a baby should be born. And so it's called the Friedman's curve, and it was based on a study published in 1955 by a Dr. Emanuel Friedman. And what he did was he was an OB, so it was based on his observation of 500 Caucasian patients at a single hospital, presumably all his. So he basically graphed how often, or he would do cervical checks, and he graphed the change and how long it took for each person or each woman to dilate centimeter by centimeter. And then he extrapolated from that graph and came up with this curve to define what is normal and what should be the pace of labor. So the conclusion was that first-time birthers should need about 14 hours to go from 0 to 10 centimeters dilated, and multips, or if you've already had
in a dream world. I just want to interject right now and say, in a dream
14
world.
14 hours. And it was 8 hours for what he called experienced mothers, or it wasn't their first baby. So first of all, that'd be great. But I so not what I have seen and most of us have seen in practice for many people. And so this curve and this kind of acceptance of this being the norm we really started looking at this in the early 2000s, like 2010-ish, because there's so many people that were ending up with cesareans for a quote-unquote failure to progress. And so finally what ACOG, which the American College of Obstetrics and Gynecology, they kind of set the rules or the standards for OBs in this country, said in, I believe it was 2012 and reaffirmed it in 2014, was that we should not be holding people to that curve, that labor, quote unquote, normal labor does not need to progress that quickly. And we should not be sending people to cesareans if they're not dilating 1 centimeter per hour in active labor, which is what he said was normal. So, yeah, I hate it. And
I hate it too.
Yeah.
I feel the same way about weight gain in pregnancy because they're like a pound a week.
Yeah,
and it's more like you don't gain anything in the beginning or you gain a ton in the beginning because eating either makes you feel horrible or better.
Yeah.
And then you have like a 10-pound weight gain 1 month. And it's kind of the same way with dilation where with a first-time parent, I usually tell them if they have their baby under 36 hours, I'm ecstatic. And in that 36 hours, it's not like people are dilating like a quarter of a centimeter an hour. It's usually like the first, 24 hours of that is just getting to 6 centimeters because getting to 6 centimeters takes way longer than getting from 6 to 10. Mm-hmm. And not that you
typically,
that you can't have a stall in labor at any time because some people will stall at 8 or 9 centimeters or even 10 centimeters. Their contractions will just go kaput and they'll, if they're not medicated, if they're not medicated or they know where Pitocin is to be found, then they might just hang out at 10 centimeters without contractions for a few hours. Like that happens occasionally. It's not common, but yeah, usually it takes way longer to get to 6 centimeters, and then 6 to 10 can go really quickly.
I'm so glad you're saying this because I do feel like people have an expectation of that it has to just keep progressing and keep progressing as opposed to like slow and methodic. Like it could, slowly keep going and it doesn't have to follow a certain pattern. So that's great that you're saying this. But how does somebody approach and talk to their care provider beforehand? I'm all about the beforehand, not the during, about expectations.
I think that's great.
Oh yes,
a preventative approach.
It's not. Labor is not the time to negotiate, in my thought.
No. Well, I think that what this could be would be a really great determining factor for whether or not this care provider is right for you.
Right.
So, you might not be able to change your care provider's mind if they think, no, you should have a first baby within 14 hours, according to this outdated information by Mr. Friedman, who's apparently alive and kicking and very upset.
I shared before we started recording that as I was like refreshing my memory on all this stuff. I did some research this morning and found out that when ACOG made these statements a couple of years ago being like, this isn't what we're going by anymore, Dr. Friedman is furious and does not agree and thinks that everybody should still follow this. So, but I think to answer your question, people should be asking important questions like, to their care provider, is there a standard amount of time that you insist on doing cervical exams? Or is there a certain amount of progress that you expect or require your laboring patients to make before you suggest interventions like augmenting with Pitocin or going to a cesarean? Like just getting a sense of what their normal practice is. Do you believe in Friedman's curve? Like, are you holding,
Do you have a poster from behind you? So let's figure out.
Totally, yeah.
Do I need to drive to New Mexico to have a baby in the same place?
So just knowing and asking also, like, what is their standard for their practice on how often they want to do cervical exams, and is there ever just a subjective or like an objective amount of time that if this amount of time has passed with no progress, you're definitely having a cesarean or we're definitely doing this, assuming that the baby and the person giving birth are healthy and well and vitals are good and the person laboring has strength and energy to keep going. I am of the mind that if all of those things are in place and everyone is safe, then I don't think that there should be an objective, like you have this amount of time and then that's it kind of thing. It's a more dynamic picture than that.
I love that. And again, going back to ask ahead of time, because I've really worked with care providers that they do have a certain expectation of progress, and then it just gets bumpy. And luckily, they had an advocate, I was their doula, they had an advocate to help. But especially if a couple's on their own, or even if the birthing person's on her own, it's a really hard place to negotiate, and often they don't feel that empowered to do so in a typical hospital setting by themselves. So yeah, let's just put that out there as a conversation ahead of time. So I'm looking.
If you have, sorry, I just want to say, if you have, I know that everybody doesn't have choices with their care provider, or the ability to switch, but ask these questions early and get a doula. Obviously, I'm a huge fan, but if you can't get a doula, ask around and ask people in the birth community in each town and each city. They're going to know who are like the great supportive care providers and who are the ones that they wouldn't take their ailing dog to. Right? Like that's a thing. So ask people who know and
do your research.
Do your research and do it early. And switching care providers can be overwhelming, can be difficult. It is so worth the effort if you can switch to somebody who you are not going to have to fight with, because you deserve to have a supported experience where interventions are only suggested when they are medically necessary, not because of some subjective rule or a person's preference.
Oh, yep. I love that. 100%. So I was looking through my questions. We got through so much. Is there anything I have not asked about the cervix that you think we need to talk about?
Gosh, the cervix. I don't think I mentioned that getting positive news from a cervical check can be so encouraging and can really change the mood and change the course of labor. I mean, Allie and I had a mutual client where Allie was pretty sure she was still just 2 centimeters and everyone was depressed. And I got there and she was like, please check me. And so I did. And she was 6 centimeters. And all of a sudden she was coping great.
Yep. There's a total
shift. Feeling so good. And so sometimes it's actually really good to know, but that's individual and it's just based on the moment. And if you want to know something, you'll know you want to know. And if you don't want to know, you don't want to know.
Totally. So. And I want to defend myself there to say that I didn't say that out loud in front of our client. I took Carly aside and was like, we are all so tired.
She came out and met me at the gate. Yeah. She was like, queen.
We need help. I need help.
Well, sometimes we have kind of these emotional signposts of labor, and sometimes people just are not. Like, I remember having a client, we got there and she finally got into her room and she was talking to me as if, I thought maybe early labor. She was just talking to me. I walk in and she's like, I'm 9 centimeters, still just talking, just like,
yep.
I'm like, I would not have guessed that.
I had a birth like that this week. And I was their doula the first time too. And 4 years ago, they had their first baby. I will never forget. She was 8 centimeters, taking a shower in the hospital, hanging her upper body out of the shower, eating a piece of pepperoni pizza, chatting.
I love her.
At 8 centimeters.
Wow.
And so we all were joking, I wonder if it'll be like that again. And she had a pretty quick labor this time, but she totally was chatty and jokey the whole time.
Yeah. Yeah,
so
everyone's
never
different.
know.
You should never have a clear expectation of what your birth is going to be like.
Yeah.
You just don't know.
You don't know. And the same person could have 2 very different births. My first was about 42 hours. My second was about 4. I mean, same body.
There you go.
2 very different children.
Dude, those are the best second birth.
Was that so great?
Wow, did not feel good.
I do love a second birth. You're statistically, you're going to be a little quicker. All right, so we're going to take a super quick break, and when we come back, I'm going to ask you both can throw in one tip or piece of advice you would like to offer for new or expectant parents. We'll be right back.
This podcast is sponsored by Skylight Calendar. Let's be real. Running a household can be exhausting and chaotic. And finding the perfect Mother's Day gift, it's not exactly a no-brainer. Until now. The Skylight Calendar is the best way to organize the family and give everyone, especially mom, some peace of mind to enjoy the things that matter most. The Skylight Calendar is a smart, touchscreen calendar that keeps track of and manages the chores, dinner planning, groceries, and to-dos for the whole family. The Skylight Calendar automatically syncs each family member's digital calendars and displays them all together on one color-coded touchscreen. It even doubles as a digital picture frame, so you can finally share all those special moments that are just sitting on your phone. As a limited-time offer for our listeners, get 15% off your purchase of a Skylight Calendar when you go to skylightcal.com/easy. That's SKYLIGHTCAL.com/easy. Get 15% off your Mother's Day purchase now at skylightcal.com/easy.
Okay, and we're back. So, what do you want to lay out there?
Oh man, do you have something off the top of your head, Queen? I'm kind of.
Oh, I have go-tos. Absolutely.
What's your go-to?
For new parents, I always say, like, pick a care provider that you feel really comfortable with, and then have very fluid expectations and hopes for your birth. Just like learn as much as you can, as much as is helpful for you, and then just understand that you can influence your birth, but you can't control it.
That was going to be mine. It's such a good one.
It's mine. I came up with that saying. I use it as much as possible. But yeah, I really believe in that because I feel like that is the best thing to reduce birth trauma, which is the best thing to do to enhance your bonding with your baby, enhance your experience, and overall just feel more satisfied with your birth. Like we talked with somebody a couple weeks ago about how loss of control of your labor doesn't mean loss of consent, and I think it's really important to differentiate and to put your expectations more on consent and information rather than putting your expectations on performing, because this is an involuntary process and no one should ever feel like I need to perform or I failed at my birth. No one should ever feel like that because most of the birth depends on the baby.
Absolutely. I love that.
Yes. Beautifully said. I think the only thing I would add to that is that you are so worth investing in this experience. And that means a lot of times that means spending a lot of time and energy and oftentimes extra money to get the information and the support for your birth experience. And I know a lot of families can feel overwhelmed or a little burdened by that, but I promise it is so worth it. Like we spend more money in this country, more time and energy and money researching like our next flat screen TV than we do on the kind of birth experience that we want or care provider or birth education. And so I just like to empower people that like, this is worth it. And what we do matters at this time of life for us and for our babies.
Oh, everything. Yes. Okay. Where can people find your work?
We have our podcast, the Birth Kweens podcast, and it's KWEENS. Queens.
And I'll have it in the show notes.
Perfect. So we have our website, birthkweens.com, and then you can find the podcast anywhere that podcasts are available. And we're on Instagram as well. And we have a private Facebook group, the Birth Kweens podcast community. We're both on Instagram. What else am I missing?
Allie Feroah. We both have websites. So if people are in the San Diego area and want to work with us, they can.
Yep. We can. I'll send you the links for all that if you want to include in the show notes.
Yes, I certainly will. Oh, it has been such a joy and pleasure to talk with you guys. And we're so on the same page with so much. So I'm literally sitting here like, yes, shaking my head. I'm like, yes, this is exactly what I want the community to know.
It always feels so good.
It does. When you find like-minded people, oh, it's the best.
Yeah, I know. It was so fun talking to you, Deb.
Thank you so much. Well, thank you. Go enjoy your day. Be well.
You will. Thank you.
This has been an episode of Yoga Birth Babies, produced by Prenatal Yoga Center. You can catch us on Facebook, Twitter, Instagram, and Periscope. I'm Deb Flaschenberg. Thanks for listening.
With the Lucky Land Slots, you can get lucky just about anywhere.
This is your captain speaking. We've got clear runway and the weather's fine, but we're just going to circle up here a while and get lucky. No, nothing like that. It's just these cash prizes add up quick. So I suggest you sit back, keep your tray table upright, and start getting lucky.
Play for free at LuckyLandSlots.com. Are you feeling lucky? No purchase necessary. Void where prohibited by law. 18+ terms and conditions apply. See website for details.